Welcome to Impact Signals, Social Impact at the Scale of AI. I'm Charlie.
And I'm Sarah.
It's Friday, August 14, 2026, episode 103. Today, the money and the mandates for public interest AI are arriving ahead of the people who have to run it. The first national assessment of AI in U.S. emergency management counts more than 1,100 products and then points at staffing. A $100 million grant asks 4 state health departments to double a cure rate in 2 years, and in Hot Springs, South Dakota, patients tell reporters they are not sold. We start in the United States, where the AIDE initiative, AI for Disasters and Emergencies, published the first assessment of AI across the country's emergency management community on August 11. It is led by the Markle Foundation with Aspen Digital and the research organization RAND.
What makes this significant is that it counts both sides of the market at once. RAND Scan identified more than 1,100 AI-enabled products from more than 700 companies, aimed at prediction, situational awareness, administrative automation, and dispatch support. That is the supply side.
The demand side is thinner than the catalog suggests. The report finds most state, local, tribal, and territorial emergency management offices are at the earliest stage of adoption, and many of the smaller ones run on 1 full-time staff member or fewer, leaning on part-time and volunteer personnel.
The model is the easy part. 1,100 products sitting across from an office of 1 person is a capacity question, and the report lands on governance, procurement capacity, and workforce skills as the binding constraint.
It ships as 3 documents. The main report, AI for Disasters and Emergencies, A Way Forward, a practitioner study from Aspen Digital, and RAND Market Study on Supply and Adoption Pathways. State Scoop and GovTech both led their coverage on the same conclusion.
For practitioners, the operational question this reframes is who inside a 1-person office evaluates, procures, and supervises any of those 1,100 products. All 3 documents are public as of August 11, and the Aspen Digital study is the one written for those offices themselves, which is the closest thing the sector has to a template.
Second signal. On August 13, the Common Health Coalition announced $100 million from the OpenAI Foundation for an initiative it calls Breakthroughs to Follow Through. The first target is Hepatitis C.
What makes this significant is the number attached to it. The stated goal is to at least double Hepatitis C cure rates in 8 participating states and localities within 2 years. That is a figure a health department can be held to in public, on a clock.
NextGov reports the first grants go to Alabama, Illinois, Louisiana, and Massachusetts. The tools in scope are unglamorous by design: generative AI to identify patients who should be screened, outreach platforms, clinician co-pilots, and patient navigation. Grants are platform agnostic, so jurisdictions choose their own tooling.
The constraint this money targets is operational delivery, treatments that already work and do not reach patients. Dave Chokshi, who chairs the coalition, framed it as jurisdictions determining which tools help existing medical breakthroughs actually reach the people who need them, and the American Hospital Association put its executive vice president and chief operating officer, Michelle Hood, on the record behind the Hepatitis C push. More jurisdictions are due over roughly 6 months, with HIV prevention and curable cancers named as the next phases.
Moving to rural healthcare. KFF Health News published a reported piece on August 11 from Hot Springs, South Dakota, a town of roughly 3,400 people with a 25-bed independent hospital and a Veterans Affairs hospital.
What makes this significant is the size of the evidence base being asked to carry the spending. Just 26 peer-reviewed studies on AI in rural healthcare were published between 2010 and April 2025. That is 15 years of literature.
States are steering money from the $50 billion federal Rural Health Transformation Program into AI for rural health organizations. Health Secretary Robert F. Kennedy Jr. has told senators that AI nurses can provide concierge care to rural patients, and Mehmet Oz, who runs the Centers for Medicare and Medicaid Services, has promoted AI-based avatars for rural mental health.
The second thing the reporters put on the table is infrastructure. Rural facilities frequently lack the hardware, the technical staff, and the internet speeds these deployments assume. Mississippi, Utah, Kentucky, North Dakota, New Hampshire, Connecticut, Texas, and Wisconsin are planning AI investments anyway, and the patients quoted are blunt about wanting care to stay between them and their doctor.
Story 4 takes us to India. Your story profiled seismic hazard and risk investigations, incorporated in Roorkee in September 2020 as a spin-off from the Indian Institute of Technology Roorkee's Earthquake Engineering Department, selling seismic instrumentation designed and built in India rather than imported.
The architecture is the interesting part. Its on-site system, Boo-Warn, uses 3 sensors and a single data acquisition unit and detects the first arriving wave at the building itself, instead of depending on a regional sensor network.
The company says the institute has transferred the technology behind one of its units, with several pieces of core equipment patented. The same logic runs through its seismic switches for homes and offices, which cut power or gas automatically once shaking crosses a threshold, with no operator in the loop.
Regional earthquake early warning has always been gated on national-scale sensor networks and public alerting, which is why so few countries have it. Moving the unit of coverage from the country to the structure is a different procurement conversation for a hospital or a school. The claim to watch is deployment count. The profile establishes the design and the patents, not how many buildings are running it.
On the disaster watch, a magnitude 7.4 earthquake struck 5 kilometers south of San Jose del Palmar, Colombia, on August 10 at a depth of 110 kilometers. GDAX, the Global Disaster Alerting System, issued a red alert with an estimated 5.2 million people in the strongest shaking zone. UNICEF reported expanded assistance following the quake. 2 more on the watch. Flooding in China remains under an orange alert issued August 7, and Chinese state media reported central relief funds allocated for typhoon-triggered flooding across 3 provinces on August 14. Drought across the Democratic Republic of Congo, Kenya, Tanzania, and Uganda is still running, on a record dated July 29.
The Colombia number is the argument story 4 is making. 5.2 million people inside the strongest shaking zone is exactly the exposure a national sensor network covers unevenly, and a single hospital or school may sit nowhere near it. That is the gap a 3-sensor unit bolted to one building is aimed at.
On the calendar, the State and Local Government AI Summit runs August 19 and 20 in the United States, hosted by GovTech. The organizers' listing has it as invitation only.
That is 5 days out, and the room is the audience the emergency management assessment is about, the state and local teams doing the procuring. For anyone not on that invitation list, the Aspen Digital Practitioner Study covers the same ground and is public today.
The through line today is that the money and the mandates are arriving ahead of the people and the evidence. 1,100 products sold into one-person offices, $100 million tied to a cure rate, and $50 billion in rural health money moving against 26 studies.
Each of these has a date on it. The Hepatitis C target runs on a 2-year clock with more jurisdictions named inside 6 months, and the emergency management assessment is public as of Tuesday. Governance and staffing are the line all 3 have to cross.
That's Impact Signals for Friday, August 14, 2026. If this briefing is useful, subscribe wherever you get your podcasts. Check us out at impactsignals.ai and share it with someone working in the field.
Stay ready.